Imagine a storm suddenly taking over your brain's electrical grid.
Oh, yeah.
In an instant, you lose control of your body, your awareness, your safety.
Right.
That is the terrifying reality of an unprovoked seizure. And, you'd think treating something that extreme would be straightforward, like engineering.
I hope so, yeah.
Right. Like you break an arm, the x-ray shows a jagged white line, the doctor sets the bone, done.
If only it were that simple.
Exactly. But stepping into the world of neurology specifically, this delicate, high-stakes balancing act of controlling the brain's electricity, it's a completely different ballgame. The diagnostic landscape is just incredibly murky.
It is the absolute definition of muddy waters. I mean, we are dealing with these invisible storms that can alter the course of a life in seconds.
Wow, yeah.
And the sheer unpredictability of it all is what makes the choices we make about how to calm those storms or prevent them so intensely critical.
Which brings us to the mission of today's deep dive. We are exploring the absolute cutting edge of neurology for you today, drawing directly from the February 2025 issue of the medical journal Continuum.
Great issue.
It really is. We're focusing on the rapidly evolving world of anti-seizure medication 2025. And our goal here isn't just to rattle off a list of unpronounceable drug names.
No, nobody wants that.
Right. We are looking at how medical decision-making itself is transforming. We're going to explore how artificial intelligence is predicting treatment outcomes, how doctors are creatively repurposing drugs that, frankly, used to terrify the public.
Oh, yeah, we'll get to that.
And how they navigate the incredibly complex chemical maze of human reproduction.
To really appreciate where we are in 2025, you have to understand the speed at which this specific field is moving.
Okay, set the stage for us.
So if we look back to the early 90s, like before 1993, neurologists essentially had maybe 7 or 8 major agents to choose from.
Just 8.
Yeah, very limited toolbox. Since then, over 20 new anti-seizure medications have hit the market.
Wow, over 20.
Exactly. And while those older foundational drugs, things like carbamazepine and valproate, they're undeniably powerful at stopping seizures, they bring a massive amount of baggage.
When you say baggage, my mind immediately goes to side effects, like the classic fatigue or the dizziness you always hear about.
Side effects are a huge part of it, for sure.
Yeah.
But the baggage is also heavily pharmacokinetic.
Meaning how the body actually processes the drug.
Right. These older drugs process through the liver in ways that are just notoriously hard to predict.
Oh, I see.
They interact dangerously with everyday medications, and they can severely impact a patient's cognitive function. So the holy grail in 2025 isn't just finding a chemical that stops the brain from misfiring.
Right, it's about balance.
Exactly. It's maximizing that seizure control while minimizing the collateral damage to the patient's actual ability to live a normal, functioning life.
But, before we even get into the specific medications in this new arsenal, there is this massive philosophical hurdle that the clinical data highlights.
The timing.
Right. It's the decision of when to actually deploy these drugs. So imagine you're the patient, right? You've just experienced your very first unprovoked seizure.
Terrifying experience.
Beyond terrifying. And my immediate assumption is that the doctor hands you a prescription before you even leave the hospital, just to make absolutely sure it never happens again.
Well, historically, doctors did the exact opposite.
Wait, really? They'd send you home with nothing.
The standard practice was to wait for a second seizure before officially diagnosing epilepsy and starting any kind of treatment.
That sounds crazy to me. Why wait for a second one?
The prevailing medical logic was caution. Remember that baggage we talked about? These drugs actively alter brain chemistry. Doctors wanted to be absolutely certain this wasn't just some bizarre, one-off physiological event.
Ah, okay. That makes sense.
They didn't want to commit a patient to years, potentially a lifetime of heavy medication if they didn't have to.
But the definitions changed, didn't they? The 2014 guidelines shifted that entirely.
They did. Neurologists are now allowed to diagnose epilepsy after just one single seizure, but only if the statistical risk of a second one happening over the next 10 years is over 60%.
Over 60%. So how do they figure out that risk?
Well, if a patient has a prior brain injury, or if their EEG scan shows what we call epileptiform abnormalities.
Which are what? Exactly.
They're essentially these spiky, irritable brainwave patterns that indicate the cells are primed to misfire. If they see those, the risk of a second seizure basically doubles.
Okay, so then the physician is faced with this profound choice. Do we treat immediately or do we wait and watch?
Exactly.
I really want to spend some time on this because this is where the artificial intelligence comes in and the mechanics of it are just brilliant.
Oh, the Markov model.
Yes. The latest Continuum update details this 2025 development using something called a Markov decision model. And for you listening, think of the Markov model like a chess computer.
That's a great way to look at it.
Yeah, right. When you play chess against a machine, it isn't just analyzing the board as it exists in that exact second. It is simulating thousands of possible futures, looking 10, 15 moves ahead.
Right, and calculating the exact mathematical probability of every single variation.
Exactly. So how does that apply to medicine?
That chess computer analogy captures exactly how we use the Markov model in medicine today. Researchers use this AI to simulate a massive, incredibly complex clinical trial to definitively solve this first seizure dilemma.
So they fed it patient data.
Yes, the AI analyzed varying features of hypothetical patient cases to see whether immediate treatment or deferred treatment maximize what the medical field calls quality adjusted life years for adults.
Quality adjusted life years. Okay, let's break that down. So we aren't just measuring how long a patient survives, but the actual quality of that survival.
Spot on. Living 10 years heavily sedated by a drug is mathematically scored very differently than living 10 years completely symptom-free.
And that distinction is just vital. So what did the chess computer decide?
The AI calculated that across a wide range of clinically relevant variables, immediate treatment is the optimal path.
Wow.
Yeah, it mathematically proved that starting medications right away significantly reduces the risk of a second seizure within the first 2 years.
And normally that risk sits somewhere between 21 and 45%?
Exactly. The AI showed that cutting that risk down early maximizes the patient's overall quality of life.
But, and this is what blew my mind, the clinical data reveals a really counterintuitive twist to this.
Yeah, the long-term data.
Right. The AI chess computer also confirmed that giving the patient medication early doesn't actually change the long-term end game.
It does not. It doesn't improve the long-term prognosis for sustained seizure remission after 3 years.
So wait, whether you treat on day 1 or day 400.
If you are going to eventually achieve long-term freedom from seizures, or if your epilepsy is going to be stubbornly resistant, that outcome remains exactly the same.
That is a staggering realization. I mean, you are taking powerful medication immediately just to buy yourself 2 years of safety.
Yes.
You are actively preventing the sheer psychological and physical trauma of experiencing that second seizure, but you're weighing that benefit against the guaranteed daily risk of the drug's side effects.
It is a pure, unadulterated risk management calculation.
That is so intense.
Yes. But the AI is giving us the statistical confidence to balance that equation. It proves that managing epilepsy isn't just about, suppressing the electricity in the brain.
It's about the patient's actual life.
Exactly. It's
Yeah.
about protecting the patient's lived human experience over those first crucial 24 months of uncertainty.
All right, so the AI has run the numbers and tells us we should treat immediately. The table is set. Now we have to look at the actual tools.
The fun part.
Yeah, we have this arsenal of over 20 newer drugs. Let's look at how targeted these medications have become, starting with the newest FDA-approved drug on the list, ganaxolone.
Ganaxolone is such a great example of how hyperspecific pharmacology is becoming right now. It's a neuroactive steroid, and its mechanism is just fascinating.
That's it.
Well, it targets a completely unique binding site on the GABA receptors in the brain. And GABA is essentially the brain's primary inhibitory neurotransmitter.
So it's the brakes.
Exactly. When it binds to a receptor, it tells the overly excited neurons to just calm down and stop firing.
But what caught my eye in the data wasn't just the receptor science. It was this strange, incredibly human detail about how the drug actually gets into the system.
Oh, the food interaction.
Yes. The absorption rate, the bioavailability jumps massively if the patient eats it with a high-fat meal. I mean, why does a high-level neurological steroid care if I eat a cheeseburger?
It all comes down to the chemical structure of the drug itself. Ganaxolone is highly lipophilic, which means it dissolves in fat, not water.
And our stomachs are mostly water.
Right. Our digestive system is a very watery environment. So if you take the pill on an empty stomach, it really struggles to absorb across the intestinal wall and get into the bloodstream.
Oh, okay.
But if you introduce dietary fat, the drug binds to those lipids, hitches a ride, and its absorption just skyrockets.
That is so cool.
It really highlights how deeply intertwined advanced pharmacology is with basic human digestion. And it's also worth noting how specific its use case is.
Right, it's not for everyone.
No, Ganaxolone is currently only indicated for seizures associated with cyclin-dependent kinase-like 5 or CDKL5 deficiency disorder in patients 2 years and older.
CDKL5. Okay, so ganaxolone proves how targeted we can get with a specific receptor and a specific genetic disorder. But what happens when you have a patient whose seizures are completely resisting standard treatments?
Then we have to look at drugs like cenobamate.
Right. The data highlights cenobamate for drug-resistant focal epilepsy, and it notes that it shows truly exceptional rates of seizure freedom.
And complete seizure freedom is the absolute dream scenario for a neurologist.
But I'm looking at the administration guidelines, and I was honestly confused. It requires this painstakingly slow titration process.
Extremely slow, yes.
You have to start at a minuscule 12.5 milligram dose and increase it over many weeks. Like, why put the patient through a weeks-long waiting game? If the drug works, why not just blast the brain with the therapeutic dose immediately and stop the seizures today?
Because the immune system would likely mount a catastrophic response.
Wait, catastrophic?
Oh, absolutely. If you introduce cenobamate to the body too quickly, it carries a significant risk of triggering severe allergic skin reactions, specifically a condition called DRESS syndrome.
DRESS syndrome, that sounds awful.
It is. This isn't just a mild rash. DRESS syndrome involves widespread skin eruption, fever, and internal organ inflammation. It can be totally life-threatening.
Good Lord.
So the body basically has to be slowly tricked into tolerating the compound. The physician and the patient are forced to play this incredibly patient, long game.
That's a huge trade-off.
It is. You hold the key to stopping the seizures, but you have to walk a tightrope for weeks just to safely get the patient to the dose that actually works.
Speaking of the body mounting a catastrophic response, we have to talk about fenfluramine.
I knew we'd get to this one.
I genuinely had to do a double take when I saw this in the 2025 update. Wasn't fenfluramine half of the infamous fen-phen weight loss cocktail?
Yep.
The drug that caused a massive medical scandal in the late 90s because it was literally destroying people's heart valves?
It is the exact same compound.
It's wild. How does it even work for epilepsy?
Well, fenfluramine works by increasing serotonin levels in the brain. Specifically, it disrupts the storage of serotonin in the nerve cells and reverses the serotonin transporter function, which basically floods the synapses.
Okay.
And for reasons we're still, fully mapping out, this intense serotonergic action is highly effective at halting certain types of severe intractable seizures.
But you can't just ignore the heart valves. How is a drug that was pulled from the market in disgrace for causing pulmonary hypertension and cardiac damage now being given to patients with epilepsy?
It really comes down to understanding the mechanics of toxicity and the demographics of the patient.
Okay, explain that.
When researchers revisited fenfluramine for pediatric epilepsy, specifically for devastating conditions like Dravet syndrome or Lennox-Gastaut syndrome, where a child might suffer dozens of seizures a day, completely stunting their cognitive development.
Heartbreaking.
It is. But when they looked at it for these kids, they discovered two crucial differences. First, the dose required to control these seizures in children is a fraction of the massive doses adult patients were taking daily for obesity.
So it's a microdose.
Exactly. And second, in these young pediatric populations taking these microdoses, the long-term cardiac valvular disease simply hasn't materialized in the same way.
Wow. We took a compound that was a global medical scandal, completely reevaluated the dosage mechanics, applied it to a completely different demographic, and found out it can give a child with a severe epilepsy syndrome their life back.
It's an incredible redemption story. It proves you can never truly close the book on a chemical. Context and mechanism dictate absolutely everything in pharmacology.
That is so true. Well, let's shift from the successes to the frustrations.
Always plenty of those.
Right. The clinical data points out a stubborn reality. If one drug is good, two isn't always better. How do neurologists handle patients whose seizures simply don't stop with that first medication?
This introduces a vital concept the continuum update stresses called pseudo-resistance. Before a neurologist assumes a drug has chemically failed, they have to investigate whether the failure is an illusion.
Pseudo-resistance, fake resistance.
Exactly that. Sometimes the drug is perfectly capable of stopping the seizures, but the surrounding circumstances are sabotaging it.
Like what?
The most common culprit is poor adherence. The patient simply isn't taking the medication on the required schedule.
Missing doses.
Right. Or the patient is triggering the seizures through extreme lifestyle factors. Severe sleep deprivation or heavy alcohol use can easily overpower a medication.
Just overwhelming the drug's capacity.
Exactly, which is an incredibly common issue in idiopathic generalized epilepsy.
And idiopathic generalized epilepsy means the seizures are originating from both sides of the brain simultaneously, often with a genetic link, right?
Yeah.
And they are highly sensitive to exhaustion.
Spot on.
The update also mentions pseudoresistance could literally just be a misdiagnosis.
Oh, happens all the time.
Like a doctor prescribes a narrow spectrum medication meant for focal seizures, seizures starting in one specific part of the brain, but the patient is actually having generalized seizures.
Right. So the drug fails because it's just the wrong tool for the job. The drug never stood a chance.
But what if they rule all that out?
Right. If a physician meticulously rules all of that out, the diagnosis is perfect, the patient takes every single pill, they get 8 hours of sleep, and the seizures still break through, then you are dealing with true resistance.
And that forces the transition to polypharmacy, combining drugs.
Yes.
And combining drugs isn't just throwing pills in a blender. Like, if a brain cell is a fortress and a seizure is an invading army, you have to defend the fortress strategically.
I like that analogy.
The clinical data gives a perfect example of how not to do this. Mixing lacosamide with another sodium channel blocker, like carbamazepine. If the sodium channels are the front doors to the fortress, both of these drugs are trying to jam the exact same lock.
Right.
You don't need two guys fighting over the same door.
That fortress analogy perfectly explains why combining mechanisms of action improperly is so dangerous. Because lacosamide and carbamazepine are competing for the exact same sodium channels, they don't enhance each other.
They just get in each other's way.
Worse, they back up in the system. The overall efficacy actually drops, and the drug toxicity massively increases.
Oh, wow.
Yeah, so the patient experiences double the side effects. The dizziness, the double vision, with less seizure control.
That's the worst of both worlds.
It is. The data also highlights brivaracetam being completely ineffective if combined with levetiracetam, because they both target the exact same synaptic vesicle protein.
So what's the correct way to defend the fortress? How do you combine mechanisms successfully?
You lock the front door, and you calm down the people inside.
Oh, nice.
The best documented synergistic combination is lamotrigine paired with valproate. The evidence shows they have super additive efficacy.
Super additive, meaning 1 + 1 = 3.
Basically, yes. The benefit of the two working in tandem is significantly greater than the sum of their individual parts. They hit completely different targets in the brain's electrical pathways, enhancing each other's ability to stabilize the network.
But the danger of polypharmacy extends way beyond just mixing seizure meds. It's about everything else entering the patient's body.
Absolutely. The liver is the body's chemical processing plant.
Right, and there is a terrifying example in the research regarding carbamazepine. So a patient has their epilepsy perfectly controlled. They get a mild bacterial infection, and a primary care doctor prescribes an everyday antibiotic, erythromycin. What actually happens chemically in the liver?
Well, erythromycin acts as an inhibitor for specific cytochrome P450 enzymes in the liver.
Okay.
And those are the exact enzymes responsible for breaking down and clearing carbamazepine out of the bloodstream.
no.
Yeah, so the antibiotic effectively shuts down the liver's disposal workers. The patient takes their normal, totally safe daily dose of their seizure medication, but because the disposal system is offline, the carbamazepine accumulates in the blood to highly toxic levels.
Just from taking a standard antibiotic for a cough,
Yep.
it really illustrates how a neurologist in 2025 doesn't just look at brain waves. They have to be an electrician, a liver chemist, and a detective all at once.
And crucially, a genetic counselor.
Which leads us to the most complex, high-stakes demographic discussed in the entire 2025 update: people with epilepsy of childbearing potential.
The gravity of this demographic is immense because when a doctor treats a patient who might become pregnant, they're no longer just treating the brain of the adult sitting on the exam table.
Right. The pharmacological choices they make will literally dictate the neurological and physical development of a fetus.
Exactly. The American Academy of Neurology actually published highly anticipated practice guidelines in May 2024, just to map this out.
Yeah.
We talked earlier about valproate and its baggage.
Right.
When it comes to pregnancy, the guidelines are absolute. Valproate must be strictly avoided.
And the statistics in the latest research are deeply unsettling. There is a 10.3% risk of major congenital malformations and neural tube defects.
Over 10%.
Yes.
Okay.
And for clarity, a neural tube defect is when the embryonic structure that becomes the brain and spinal cord fails to close properly, leading to conditions like spina bifida. But the physical malformations are only half the story, right?
Sadly, yes. The neurodevelopmental outcomes are equally severe. Children exposed to valproate in utero have significantly higher rates of autism spectrum disorder. They have measurably lower IQs, and longitudinal studies demonstrate significant, lasting difficulty in processing auditory, verbal, and visual material.
I have to ask the obvious question here. If valproate has a 10% chance of causing major physical malformations and severe cognitive deficits in a developing fetus, why is it still legally on the market? Why hasn't it been banned and replaced by the 20 newer drugs?
That touches on the uncomfortable truth of epilepsy management. For certain generalized epilepsies, particularly juvenile myoclonic epilepsy, which causes sudden shock-like jerks of the muscles, valproate remains one of the most highly effective treatments we possess.
So it works when others don't.
In some complex cases, it is the only compound that stops the seizures. It proves that in neurology, drugs aren't inherently good or evil. They are calculated tools.
Right.
If you have a male patient or a patient who is absolutely certain they cannot or will not become pregnant, valproate might be the miracle drug that gives them their life back.
So the tool has to match the specific patient profile. Now, valproate isn't the only trap. The guidelines highlight a chemical cascade with topiramate that is incredibly insidious.
Yes, topiramate carries an 18.5% risk of intrauterine growth restriction, meaning the fetus fails to develop to a normal weight and size in the womb.
18%.
It's high. But what makes topiramate uniquely dangerous for family planning is how it interacts with oral contraceptives.
This mechanism blew my mind. If a patient takes a higher dose of topiramate, anything over 200 milligrams a day, the drug kicks those liver enzymes we talked about earlier into absolute overdrive.
Yes, it induces the CYP3A4 enzymes. And those enzymes aggressively metabolize and shred ethinyl estradiol before it can do its job.
And ethinyl estradiol is the active synthetic estrogen in most oral birth control pills. So the seizure medication is actively destroying the birth control pill in the bloodstream.
Precisely.
The patient thinks they are safely protected from an unplanned pregnancy, but chemically, they aren't. And if they do unexpectedly conceive, the very drug that caused the birth control to fail now puts the fetus at an 18% risk of growth restriction.
It is a terrifying biological trap, which is exactly why the 2024 guidelines mandate that prepartum counseling must begin the very first day a medication is prescribed to anyone of childbearing potential.
You can't wait.
You absolutely cannot wait until the patient mentions they are trying to conceive. The safer alternatives identified by the data are drugs like lamotrigine, levetiracetam, and oxcarbazepine.
And their risks.
With those specific agents, the malformation risks drop to a much safer baseline of 3% or less.
That's a huge difference. And the research also heavily stresses folic acid supplementation, right?
Foundationally important. Supplementing with at least 0.4 milligrams of folic acid daily is crucial for this demographic to help mitigate the risks of those neural tube defects, regardless of which medication they are prescribed.
Stepping back and looking at the sheer scale of this puzzle, it is a profound testament to human ingenuity. I mean, we are using artificial intelligence to simulate thousands of clinical trials to calculate the exact quality of a patient's life. We are taking disgraced weight loss drugs and painstakingly calculating microdoses to save children from devastating syndromes. And we are mapping out complex liver enzyme interactions to ensure we protect not just the adult patient, but the literal architecture of the next generation's brains.
The progress in anti-seizure medication 2025 is remarkable, it really is. But the latest Continuum update leaves us with a very humbling reality check.
Oh, what's that?
Despite the AI, the massive arsenal of drugs, and the intricate metabolic mapping, approximately 1/3 of all epilepsy cases today are still categorized as having an unknown etiology.
1 out of every 3 patients.
Yeah, we can measure the electrical storm perfectly, but we have absolutely no idea what is actually causing it.
That is
But the frontier is shifting. We are getting exponentially better at identifying autoimmune causes, situations where the body's immune system gets confused and launches antibodies that attack the brain's receptors.
okay.
And we are rapidly unlocking the human genome to find microscopic genetic mutations. So the question we are facing as we look beyond 2025 is this: How long will it be before we stop treating epilepsy purely as an electrical problem and start treating it at its root as an immune system or genetic glitch?
Wow. That reframes everything. I mean, we started this deep dive talking about that broken x-ray machine, looking for the jagged white line in a murky, invisible landscape.
Right.
But maybe the problem isn't that the neurological x-ray machine is broken. Maybe we've just spent the last century obsessing over the electricity when we should have been looking at the immune system and the DNA all along.
You might just be using the wrong machine entirely.
Exactly. For everyone listening, keep questioning those baseline assumptions, keep exploring the mechanics of the world around you, and keep learning. We'll see you on the next deep dive.